Well, families that don't have a lot of resources aren't going to be able to take off work is the main one. I think that's probably the main one. The disruption to life, the not being able to be compensated for missed days of work or actually losing your job because you have to go, accompany your kid. Also, I think we are making a lot of progress in getting companies to realize that they should also be including cohorts of non-ambulatory patients. Getting a non-ambulatory patient into a clinic is different, especially if you're having to fly. Flying with wheelchairs and patient lifts and toilet shower chairs and cough assist machines and BiPAP machines, it's a lot. So if you're having to fly and you're non-ambulatory, that adds a whole nother layer of burden. I think for the non-ambulatory population, home visits would be ideal. We do have some families in the Duchenne space that prefer to go to a clinic. They feel, they just like that idea. I would say for the most part, it would show that a company is appreciating the burden that they're placing on the family, and that they are really trying to come at this from a patient-centric standpoint, where we're not just thinking about how you can help us, but how can we make this as easy on you as possible. I think it shows compassion, it shows evolution. I think we are all starting to think about how we can make this easier. The other thing about Duchenne is the clinical care piece is extreme. So if you think about the things that all these kids are doing for a clinical trial, they're doing a lot of it for their clinical care too, their everyday routine care. I think about people that are maybe, in the middle of cancer treatment and they're not feeling good at all. They want to stay in the comfort of their own home. They may have infection risks that are going to be multiplied by tenfold if they have to go out. I mean, I know there's also a risk of having somebody come in the home, but not like going into a hospital. So I think that's an important one. Anybody that's kind of immune compromised would benefit from this model. I think there's a lot of press right now about this revolution medicines and pancreatic cancer. Like that kind of jump is amazing. Some of the jumps that we saw in SMA, spinal muscular atrophy treatment, was amazing. I think I work in limb-girdle muscular dystrophy too, and there's potential there for it to be amazing. But a condition like Duchenne, that's got all the complexities that I talked about already, every increment helps, and failures help too. We do learn a lot from the failures. I wish we were better at informing patients about the role that even a failed study plays overall. I wish companies did a better job at really appreciating the burden that families have by participating in trials. And sometimes we don't even hear about what an outcome was, whether it be good or bad. There's a lot of improvements to be made, but a lot of things coming out of FDA are giving me a lot of hope right now too. Some of it's not very well characterized yet, I don't think. They're coming out and they're saying things that sound awesome. But that's step one. They say things, so then it's up to us to kind of think about how we're going to apply what they're saying to our applications and our questions. Can we go through? The only way we're ever going to make big progress in rare disease is if we can do more platform approaches and more trying to get more information faster.